Officially get started, I want to go over a couple of housekeeping items. First off, my name is Mark East. I'm with the South Dakota State Medical Association. What we want to do for our call today is we want to try to leave all the phone lines open so you can interact with the speaker, ask questions. However, if we do pick up a bunch of background noise, I go ahead and mute those lines out because it can be distracting to our speaker, but then we'll open them up. Other ways that you can ask questions is you should have a chat box, and so you can type a question in the chat box, and we'll do the best we can to make sure we pick those up and to bring those forward to the presenter for you. With that, I'm going to go ahead and turn it over to Stacy with the South Dakota Foundation for Medical Care, and Stacy will introduce our speaker today.
Hi, Mark. As Mark said, I am with the South Dakota Foundation for Medical Care, and we're part of the Great Plains Quality Innovation Network, and we're excited to be partnering on this webinar series. The series covers key patient-centered care topics, and they'll be presented in 15 to 20-minute segments, highlighting provider and clinician perspectives while introducing corresponding resources and tools. Today's webinar, Where Do You Rate?, will focus on the impact of data transparency on becoming a provider champion. Every provider wants to excel at meeting the needs of their patients. Reviewing appropriate data sources can provide insight on quality of care through health outcome measures and patient satisfaction. I'd like to introduce our speaker, Dr. Daniel Heineman. Dr. Heineman is an experienced physician now working as the Chief Medical Officer for the Sanford Clinic and Sanford Health Network, as the Associate Vice President of Health Policy. He has experience in the area of legislative affairs, quality, and safety. He's the President of the South Dakota State Medical Association in 2013-2014 and named South Dakota Family Doctor of the Year in 2001. Dr. Heineman received his medical degree from the University of South Dakota School of Medicine in 1981. Thank you, Dr. Heineman, for sharing your knowledge and expertise with us today. Please begin the presentation.
Thank you, and thanks, Mark, and good afternoon, everybody, and welcome to this webinar. I like to also think I should put on my CV that a lot of my education came from school hard knocks, because a lot of it is a lot of learning as we've gone along in this journey to help my colleagues and a lot of clinicians understand the importance of needing to be transparent around data. And I think that's been really key. Change isn't necessarily about change. Change is really about what somebody perceives as a loss. And when you go about data and you become transparent with data in terms of allowing a lot of people to see that data, sometimes it's about loss of control, sometimes it's about loss of your own integrity and how you feel about yourself. But we like to make sure that people understand that by sharing data, we're just trying to all be better and trying to work at improvement. I recently had a conversation about, well, why do we need to have all this data out there anyway? I think what aggregate look at data helps you to understand the big picture and helps give you kind of some snapshots of where you really need to spend your time and effort and read work that is then defined by what that data shows. And what I've got, and I want to show you today, is some of our work around colon and rectal cancer. We joined the 80 by 18 movement about a year and a half ago and have been working really hard to get our colon cancer rates up, and that's what we're going to show you here today. The other thing that you need to work really hard on is making sure that your data is as accurate as you can get it. Because I will tell you, if your clinicians find that the data isn't accurate, they find significant holes in your data accuracy, you'll have to work 2 or 3 times harder to them to come along with you on this journey to quality. So it is important that the clinicians be able to trust the data. And then that transparency is really important. So what I've got, and I'm showing you right now on the graph, here at Sanford we have 5 regions, and if you look across the top of that graph, right now I'm showing you our enterprise data, but it can be broken out in Sioux Falls, Fargo, Bemidji, Bismarck, and also we have another region that we call our network, which is all of our smaller access hospitals that have a significant amount of patient exposure as well. So this is on our quality dashboard, but I'll also tell you that every single clinician that when they open the electronic medical record, there's a quality dashboard that's immediately available to them that shows them their individual data and where they compare with their peers, where they compare with the people within their site, care center, within their region, and across the enterprise. I'm not going to show you that data because I don't want to be sensitive, but this will give you a look. And now this data, and we're a little bit better. We're in some of our regions, we're right at about the 80% level. But I also want to show you another look at some of the data. This can be actually, you can find it at a clinic level. So what can happen, and this is in our Sioux Falls region, you can hover over those clinic locations in the live environment and pull up the clinic. A clinician can then click on that clinic location and it'll take it down to the individual provider level to show them where they are in comparison to the clinic. As you can see, we do have a couple of locations that are now above the %. They're smaller clinics with smaller numbers, but nonetheless they've made that, they've bumped up above that 80%. We expect over the course of this calendar year to see a lot more blue now as our efforts to get our colon cancer screening rates up above that 80% are really starting to show some significant benefit. But what we're after today is to show you how you make this data available to individual clinicians. This particular website is available to our non-physician members, our nurses, our health coaches, our directors, and a variety of other individuals who are working with us on these projects. Individual physician data is also, like I said, part of right when they open up the electronic medical record, the dashboard, and all of the things that we're measuring available to them. And you can get some idea on the top of that graph, some of the things that we're measuring and some of the things that are then available. We'll be adding to this list depression because we participate in Minnesota Community Measures Project, so we'll be adding a couple more. Asthma will be added to this one as we've developed those tools now. So there'll be quite a few things that our clinicians will be able to access and once where they are, where their clinic is, where their region is, and where we are as an organization. So I think things that I would like to leave with you, transparency does move the mark. Be very careful to make sure that your data is as accurate as you can get it. I said you'll lose the providers because they won't believe you've been able to have a realistic picture. So maybe we can have some questions that will generate a little bit more conversation, and maybe we can get a little deeper into this.
Okay, phone lines are open. If you have any questions for Dr. Heineman, please go ahead. And Dr. Heineman, maybe just to break the ice, one question I have, or first our comment, pretty impressive display organizational information you're able to capture. How long have you had this system in place? And what you've seen from doing so, because as you mentioned, being able to capture data does move the mark. I'm curious what kind of changes you've seen to date.
Well, Mark, we've been able to provide these kinds of reports now for about 1.5 to 2 years. We had some different reports. The other thing that it helps throughout the entirety of Sanford is everybody's on the same electronic medical record. And our electronic medical record has the registration and registry ability so that we can pull this data at a provider level. And we've done a lot of work over the last year around our data governance so that we have definitions of what this data and how it's pulled, where it's pulled from, so that if a clinician has questions, we can drill down and show them how we've obtained this data. But these reports have now been available for about a year, over a year for our individual clinicians. We're in the process of adding advanced practice clinicians, so the nurse practitioner data will also be here, and that'll fund to our clinic level data as well. So it really takes a decision to do this, and a lot of decisions around the data governance. And by data governance, I mean the definitions. You know, it is interesting. I heard Abraham Verghese, and some of you may have heard Abraham. He's a physician that talks a lot about practice, and his definition of big data. And I hope I don't offend anybody, but he says it's like teenage sex. Everybody talks about it. Nobody really knows how to do it, but everybody claims they're doing it. We've had to spend a lot of time and effort to that definition so that we can get these graphs out to our clinician providers.
And this is Stacey. Can you talk a little bit about the reaction of the providers to the data and how you were maybe able to pull out some of the higher performers to help with your quality improvement efforts?
Well, first of all, the way we've approached this is that there are people who are outliers. It's not necessarily that you're bad, but we want people to understand that you can't just provide this data without providing tools. So it's not fair to somebody who's in a more challenging environment to just say, well, you must be doing something wrong. But we need to look at this, figure out where our opportunities are. And so the other thing that's very important when you have this kind of data is you also need to have the support sources. So we've got registries. We've got people in the practices that are helping clinicians and nurses with the data. Who do we need to contact? Who do we need to get in? Who do we need to make sure we put tools in place specifically around colon and rectal cancer screening? It can't just all be about colonoscopy. We have some patients who are just flat out going to refuse colonoscopy. So as part of this conversation, our other tools like the FIT test and the Cologuard that we're using to screen for colon cancer and make them acceptable. So we have some skeptics. We have some folks who are higher opportunities. We don't necessarily like to use the term low performer, but they have great opportunity, and we work with them to see what we need to do in their patient population to help them be a little bit more successful in this. But it's really about creating a culture that we want these measures to be better, because after all, that's demonstrating better patient care. Stacey.
Thank you.
questions that people might have. I guess, like I said, it's really important if you embark in this endeavor to make sure that you've got good definitions around what your data is, where it's coming from, and then work with your clinicians to make sure they understand the data. And we have a lot of people that are out there helping our practitioners be successful.
I was just going to say, I know that you said your data is available to your healthcare team, and did you always have it like that, or did you do the team after you started seeing the changes with data transparency? Did you start with just the providers and then expand it to the team, or did you make it available to the team from the start?
Much made it available to the team from the start, maybe not as granular, but maybe the aggregate data, because it was important for the team to understand where we needed to go and where are we and where do we need to get. So the granularity has come last little less than a year, because our data has gotten better and our ability to pull data and the reporting and the commitment. So initially it was more aggregate to the team so that they knew where their location was. But right now, most people have, most of this data is available to the team. It's not without some concerns, because some physicians were worried that this would reflect poorly on them. Again, we're not necessarily about whether or not you're a good clinician or a bad clinician, if you will. It's all about what can we do to make sure that our patient care is better. And that's been very helpful in that approach, so that we don't single clinic out. It's more about the opportunity. Most physicians want the right thing. Most physicians and clinicians are competitive. You don't get level of expertise without being a little bit competitive and always wanting to do a better job, and so we take advantage of that as well.
Dr., this is Mark. Could you speak a little bit on your process of ensuring, well, first off, setting your definitions and ensuring the integrity of your data? And I would be curious about hearing a little bit more of your team and how they go out and interact with your physicians regarding the data findings and evaluating their healthcare processes and so on.
Well, definition was in our what we call our enterprise data analytics team. They used our quality metrics, and we're currently using, like I said, the Minnesota community measures, as well as the 80 by 18 metrics for this particular measure on colon and rectal cancer. So we identified what our metric was going to be, what we were going to go after, and began pulling that data from the electronic medical record. Now, some of what we have found in some of our physicians whose data isn't as good as where we wanted it to be was the way the data was documented. The system can't pull things from, it's not smart enough to go out and find it in text. So we've had to make sure that we've satisfied our best practice alerts around health maintenance, and that it's in the right place within the electronic record, and that if that, let's say, an individual had their colonoscopy at another system or moved into our health system, that information, then we need to make sure that we go back, find it, enter it in. That's work is done by a lot of our quality teams and helping the individuals within the practice who are helping clinicians understand their data, look at it a little bit. And we can run reports on who's at the age of 50, whether they've had a colonoscopy, and if they haven't, and it doesn't make sense, we can go in and look at the record, make sure it's been documented properly. We've been doing a lot of that over the last year, so now we're feeling that our data is far more accurate. And then as new data comes in, we make sure it gets placed in the right place, and it satisfies what we call our health maintenance work, know that it's in the right place and it can be measured properly. Many of the quality people are at a system level. They work with our practices, work with our health coaches, who make up a big part of a team, and the folks within the practices who manage the registries of patients. So all of our patients who are 55 and older, 50 and older, would be in a colorectal cancer registry. And we'd be able to see who hasn't been screened, and look at those to make sure that that's correct. And then we go from there and drill down into the records if we need to. And we have a lot of ability to run reports in our electronic medical record, which makes it easier for us to once where if our data is accurate. We have individuals in practice, individuals who at a enterprise or system or regional level that are working with our teams on a local basis to do a better job. We have a lot of noon lunch and learns where we'll pick a topic for the month, and our clinic leadership gets on that call, and we talk about what we found, what we might be able to do in terms of helping them understand where they can improve, and then take a better look at their data. And then here are the tools that we have in place to help you be a little bit more successful. Understand FIT testing, understand Cologuard, how to make the referrals for colonoscopy, etc., and then making sure that we get that data in the record. Yeah.
Steve Schrader here with a question. Just a comment about where you think some of this data is going to be in the future, thinking of public disclosure, physician compare, et cetera. Have you thought ahead as to where it's going along in those regards?
Oh, we're already publicly reported in Minnesota through the Minnesota Community Measures. We have a number of other places that is already reporting our data, and that's what we tell our clinicians, that you can't unfortunately run and hide from this anymore. So let's make sure that the data that people are putting there and reporting is accurate. You need your help to make sure it's accurate. It's only going to get to be more prevalent with myths and MECRA and all the things that are going to happen. Our big concern is we want to make sure that we're always reporting the same apples, if you will. That if Minnesota Community Measures is wanting us to report elements on asthma or diabetes, that Blue Cross Blue Shield or somebody else is also using the same set of data metrics, so we don't confuse the end users or the clinicians. We're saying this data is reported this way and this publicly reported website, and this data is reported this way. So we're constantly trying to work with the people that we report data to see if we can't make sure that we're reporting it in the same way. I will tell you, we just had a kind of a celebration here in the Sioux Falls area, immediate Sioux Falls area. A number of our clinics are at that 80% or over, and we've been working with the American Cancer Society. We've had a grant from the Department of Health through their cancer initiatives, and we're right at, if not pushing. In fact, I think we have one clinic that's well over 80% of their patients now have been screened for colon cancer, and adding the FIT test and Cologuard as recognized tests that we are able to then capture and document has really helped us get over that 80% hurdle, because you're not going to probably get there by colonoscopy alone. Any other questions? If you have them, you can sure feel free to contact me at Stanford. I'd be happy to, either if I can answer it, I get you in touch with somebody that can.
Dr. Heineman, I was just going to ask that. You know, my thought is that, you know, for some people looking at this, it's probably a little overwhelming, certainly pretty impressive. And just one question, final question from me anyway, and perhaps Stacy may want to weigh on this too, but for some of our viewers today, you know, they may be in a smaller, could even be in an independent group, don't have this level of sophistication or a team, you know, readily available. What would be your thoughts or recommendations for somebody that wants to get started?
Well, you know, if you're a family medicine practice and you're by yourself, I will tell you that the American Academy of Family Physicians has some wonderful tools that can help an individual practitioner or a small group practice that doesn't necessarily have access but does have data that you can use. So that's one thing that I think you can make available with. A lot of the professional organizations are doing a lot to help their member. Let me get rid of this phone call there. Their members meet these initiatives. With ACRA and the new way that we're going to be transitioning from volume to value, it is important that you understand what you need to do. I know that there are some practices that are still on paper. It's going to be harder and harder to do this kind of data work with chart abstraction based on paper. So having some type of way to access data through electronic medical record is going to be really important. So my first recommendation would be, if you don't have some way of using an electronic record, you better start looking about it, because it's going to be very difficult to do this on paper going forward.
Thank you. Coming up on our time we have scheduled, any more questions for Dr. Heineman before we close for the day? Dr. Heineman, would you mind sharing your email address for those that may wish to want to contact you and follow up with you after today's call?
Sure. It's Daniel.Heineman, Heinemann, at SanfordHealth.org.
Great, thank you. Dr. Heineman or Stacy, any closing thoughts before we draw for a close today?
To everyone for participating, and I just wanted to mention too that the Great Plains Quinn has a quality payment program service center. So if you do have questions about that value-based care, you can find some more information, and they have a live chat feature and technical assistance for those who are looking for some help with quality improvement.
Have a good day, everybody.
Thank you, everyone. Have a good day.
All right.